Well, good day, everybody. This is Chris with The Ancient Scholar. I hope this video finds you all doing well. And today I'm going to be talking more about occlusion myocardial infarction. And I'm going to be going a little beyond a lot of the electrocardiographic discussions that I've had and have a little more big picture discussion. And that is to try to emphasize thinking about occlusion myocardial infarction as a broader topic, whereas ECG, electrocardiographic evidence, is a much narrower concept. And so let me kind of bring all this together. So what we really need to understand is, I think this is a critically important point to understand about occlusion myocardial infarction, or OMI, is that an OMI, again, is a type of acute coronary syndrome that represents near or complete occlusion of a coronary artery with insufficient collateral circulation that results in active infarction, injury and infarction. So you're losing muscle. All right, that is the definition of an occlusion myocardial infarction. So when we talk about electrocardiographic evidence, an ECG in some way is a proxy. It is some sort of proxy or some reflection of the possibility of the injury and infarction, but the ECG alone is just one tool, and we need to, again, broaden out things a little bit more. And I want to emphasize this because it can be very easy for us to focus on just one thing, just one finding, the ECG, right? What are all the findings that suggest OMI, and that is what an OMI is? Not exactly. An ECG is just like any other diagnostic test. For example, you think somebody has an infection, you order a complete blood count, and you notice they have leukocytosis or have an elevated white blood count. That suggests the possibility of infection, but leukocytosis can also be caused by a myriad of other things. That is roughly analogous to ECG changes like ST elevation patterns, ST depression patterns, and so on, right? These patterns of ECG changes are indicative of certain things, but taken out of clinical context don't have a whole lot of meaning, just like an elevated white blood count taken out of clinical context doesn't have a whole lot of meaning. I believe Dr. Smith does a good job of emphasizing this when he says, you would never call appendicitis an elevated white count abdominal pain, right? You really wouldn't say that. Appendicitis is, right, a very specific condition with very specific clinical components and pathophysiological components, mainly the inflammation of the appendix, right? That specific anatomical, or that specific piece of anatomy that's coming off of the ileocecal junction. Just like OMI is a very specific pathophysiological process that's going on with an acute occlusion or near total occlusion of a coronary artery. And the white blood count that may be elevated in the presence of appendicitis is roughly analogous to some of the ECG, electrocardiographic changes that we see, that we can see, that are correlated or associated with a myocardial infarction or an occlusive myocardial infarction. However, that again is just one piece of the puzzle. It is possible to have a myocardial infarction without any substantial ECG changes. That is possible. And it is possible to take somebody to the cath lab even though they have a normal ECG by all accounts. If they have history, they have risk factors, the signs and symptoms are consistent, their cardiac enzymes are elevated, they have a wall motion anomaly. When you ultrasound their heart, you have multiple lines of reasoning and evidence that point toward a specific pathophysiological process. That patient can still go to the cath lab with or without correlating electrocardiographic evidence. Again, the ECG is just one part of the puzzle. And while I have focused on the ECG primarily because that is the most relevant tool we have available to use in the pre-hospital environment, because that's kind of where my focus is on, there are a broader set of tools that come to play. Additionally, I think it is also very important to think about something known as pretest probability. All right. So prior to performing a diagnostic exam or employing some diagnostic modality, you need to have some idea of what do you really think? Like, what kind of probability are you placing on this patient having this problem that you're attempting to rule in or rule out with a diagnostic? For example, let's take a pre-hospital situation. You arrive on scene, there's a person down, they have a history of insulin-dependent diabetes mellitus. They gave themselves a dose of a short-acting insulin prior to a meal. They got a phone call. They were distracted. They didn't eat their meal, and now they have altered mental status. They're diaphoretic. They're tachycardic. They're acting strangely and bizarrely. And multiple lines of evidence suggest that this patient may be acutely hypoglycemic based on the history of the physical exam, the signs and symptoms. So going into performing more diagnostics on this patient, your pretest probability for hypoglycemia would likely be very high, right? So then what do? You obtain a capillary blood sugar, or a BGL, blood glucose level. You obtain that, and let's say that the BGL is normal. It's, say it says 70 milligrams per deciliter. Now, does that substantially change your approach to this patient? Should it change your approach to this patient, right? Should that one test, right, given how high of a pretest probability you have, completely change the way you address that patient? That is the question I would pose to you all. And the answer should be not necessarily. Now, that test should make you pull back and think about, have I failed to maybe consider some other things? Maybe there's some metabolic, other underlying metabolic issues. Maybe there is a neurological issue that I am not accounting for, right? What's the neurological exam like? Are there gross neurodeficits? Am I maybe missing a stroke, and this patient does in fact have a normal blood sugar? Or is it also possible that this is an erroneous test, right? That maybe the controls weren't right, maybe just random sampling errors can occur, right? Maybe I just need to run a blood sugar again or run it on a different machine to verify that this patient's blood sugar is in fact normal, right? Is that a reasonable, right? Are you, based on one test, when all other lines of evidence and reasoning, or many lines of evidence and reasoning, suggest one problem, and then one test says, maybe that's not, are you going to completely derail your entire thought process based on that one test? Or are you going to pull back, consider other possibilities, and then look at the test itself and see if something is going on with the test itself, right? That's what I mean by pretest probability. So if you have a patient with signs and symptoms that strongly suggest an acute coronary syndrome, the patient has concerning history, a concerning physical exam, right? And all things are kind of pointing to a heart attack, and then you run 12-lead ECG and it's normal, is that necessarily just going to completely rule out the possibility of a myocardial infarction? It shouldn't, right? It shouldn't, even if it's normal. It just says, hey, okay, well, let me think about some other things, right? And I'm still going to consider a myocardial infarction in my list of differentials. And maybe I need to do serial ECGs. Maybe we need to look at cardiac enzymes. Maybe we need to get an echocardiogram to look for a wall motion abnormality, right? And let's say more tests start coming back negative. The patient continues to have intractable ischemic chest pain, right? That alone is a reason to take somebody to the cath lab, right? So what I'm trying to do in this video is I'm trying to show that the electrocardiogram is an important diagnostic tool, but it's just one line of evidence and reasoning, and you don't want to just completely solely rely on one thing to make profound treatment decisions on how to treat patients. You need to take the entire picture into context, and you need to have some pretest probability. Like, what do you really think is going on based on all the evidence you've obtained up to this point? What's going on with this patient? And then you get the ECG, and how well does that ECG fit into the picture, right? So that's kind of what I wanted to kind of emphasize, is that you want to take a broader, more holistic approach to looking at the possibility of an occlusion myocardial infarction. And the ECG is just one tool in your arsenal, so to speak. And this is the case in many other instances, like people with abdominal pain, right? You have a long list of differentials that can cause abdominal pain, a long list of differentials that can cause elevated white count abdominal pain. And when you say somebody has appendicitis, you are saying that you think there is a very specific pathophysiological process occurring. Just as when you say you think somebody's having an occlusion myocardial infarction, you are saying, I think there is a very specific pathophysiological process going on in the coronary artery of that patient. And you need to have more than just electrocardiographic evidence to support that, right? ECG is one bit of evidence. What other lines of evidence and reasoning can you show that demonstrates you are employing sound clinical reasoning for placing a high credence in that specific differential diagnosis? So that's all I wanted to do in this video. Hopefully you all found it useful and helpful, and I'll see you all in the next video. Take care. Bye-bye.